In the last two sketches, we discussed the pathophysiology of diabetes, as well as two of the most important complications, DKA and HHS. In this sketch, we're going to illustrate some of the long-term consequences of chronic hyperglycemia and why diabetes is just bad news. Really bad news, in fact. Because when you find yourself in the Candy King's personal chamber, it's probably because you've done something wrong or crossed him in some way. And I have a feeling he's not happy with the results of the Candy 200 race we've been covering over the last two sketches. You remember, there were chocolate coins changing hands, 100 grands paydays. Obviously, the race was fixed. And the king doesn't care about how much end organ damage he causes. He wants answers. As the sketch progresses, we're going to illustrate a few important mechanisms that drive end organ injury in the setting of chronic hyperglycemia. And you know it's chronic because we've included a recurring symbol for chronic disease, an old grandfather clock. Made out of, what is that, fondant? Some red vines, maybe? Weird. First up is a process dubbed non-enzymatic glycation. It turns out that glucose-derived intermediates like to form covalent bonds with free amino groups on proteins, a process dubbed glycation. And it doesn't need the help of enzymes, so make that non-enzymatic glycation. Over time, this leads to the formation of advanced glycation end products, which will shorten to age. These irreversibly bound sugary residues are depicted by those glycated gumdrops, bound to the top of the Candy King's throne. Okay, I know what you're thinking. Yes, his throne is constructed entirely from jerky sticks. And yes, the lumbar support is amazing. Jerky is a protein, of course, and it's there to remind you that ages are latching onto proteins specifically. As with all chemical reactions, concentration matters. The degree of hyperglycemia has a direct effect on the rate and degree of age formation. This is why tight glycemic control is so important in patients with diabetes mellitus. A prominent target of non-enzymatic glycation is collagen, a major component of the vascular extracellular matrix and basement membrane. We're going to be talking a lot about vessels, actually, because many of the long-term sequelae of diabetes are directly related to macro and microvascular injury. So I want you to imagine that those sweet, sugary residues atop the throne are bound to extracellular matrix proteins in the vascular wall. Let's see what kind of damage these ages are doing. First of all, you see how the jerky is intertwined? Cross-linked, if you will? It turns out that advanced glycation end products have a direct effect on the surrounding extracellular matrix proteins, causing them to cross-link. It gets so tangled, in fact, that stuff can get caught in there. In large arteries, for example, LDLs can get trapped in the vessel wall, which may help accelerate atherosclerosis. Whoa. You hear that? That, my friends, is the king's nephew, Patch. And he's here to show us an important way these sugary age residues cause vascular damage a little more indirectly. It turns out that multiple cell types have receptors for ages, usually abbreviated RAGE, or RAGE, because it sounds way cooler. These receptors are found on vessel endothelial cells in smooth muscle, as well as inflammatory cells, such as T cells and macrophages. When advanced glycation end products bind to RAGE, it triggers a cascade of intracellular events, leading to the release of growth factors and inflammatory cytokines, depicted here by those shiny foil-wrapped chocolate cyto coins. Reactive oxygen species may be generated as well, which we usually depict as sparks, but in this scene will be embodied by those sparkly sugar crystals. Let's use a vascular endothelial cell as an example. Let's say one of those advanced glycation end products floats by in the circulation. If the endothelial cell grabs onto it with RAGE, then intracellular processes lead to endothelial cell dysfunction, local inflammation, formation of oxygen species, and release of growth factors that lay down more collagen. All of these lead to vessel damage. Expression of RAGE is actually enhanced in some cell types during diabetes and inflammation. Yeah, just let that RAGE take over. All right, let's see what we've got here. Advanced glycation end products directly mess up collagen. They also bind to RAGE on the outside of cells, triggering inflammation and growth factors. Well, there's a third piece we're missing here, and it's inside the cell. In the setting of hyperglycemia, glucose enters the inside of vascular endothelial cells. Advanced glycation end products form inside there too. In this hyperglycemic intracellular environment, cellular pathways are altered, leading to growth factor release and local cartilage production, cytokine stuff. Throw in some reactive oxygen species on the side. It's just not a good day to be a Kinder Egg. All right, let's see what all this damage looks like on a microvascular level before we look at the large arteries. Microvascular applies to complications affecting small arterioles and capillaries. One of the most characteristic morphologic features of diabetes mellitus is diffuse basement membrane thickening, represented by the thickness of the door leading to the basement. As described earlier, advanced glycation end products can promote growth factor and cytokine release. In turn, fibroblasts get activated and start laying down extra type 4 collagen in that basement membrane. At Sketchy, cartilage deposition is represented by a recurring cartilaginous shark symbol. And in this scene, we've got a few shark gummies for the grumpy nephew. The little circular gummy servant depicts what you should expect the capillary cross-section to look like on histology. That thick purple layer outlining the lumen represents the concentric layers of hyaline material around the basal lamina. Keep in mind that these changes may be seen in non-vascular structures as well, including the renal tubules, Bowman's capsule, and peripheral nerves. Despite the thickening of the basement membrane, capillaries actually become more permeable, more leaky to plasma proteins, in other words. These changes to the basement membrane, thickness and leakiness, are the hallmarks of diabetic microangiopathy. Overall, diabetic microangiopathy underlies many of the microvascular complications we'll be covering in this sketch, including neuropathy, retinopathy, and nephropathy. Speaking of diabetic nephropathy, diabetes just loves hitting the kidneys. In fact, diabetes is one of the leading causes of chronic kidney disease in the United States. At Sketchy, chronic kidney disease is usually represented with an old, shriveled-up kidney. Kinda like this shriveled little kidney-shaped raisin dude. Popped right out of his chocolate shell. Brutal. Since we're focusing on microvascular complications, let's briefly go through the expected changes at the level of the glomerulus. See the tail end of that gummy worm? Or gummy snake, rather? That's our glomerulus, and there are 4 characteristic histologic findings to look out for in the setting of diabetic nephropathy. First, expect to see that same kind of diffuse basement membrane thickening we were talking about earlier, which is why we've placed the glomerular tail next to that thick basement door. Remember, even though the membrane is thicker, it's also leakier. And that brings us to our next characteristic finding, glomerulosclerosis, which is seen as concentric thickening of capillaries and arterioles due to the accumulation of pink hyaline material. This pink amorphous goo is comprised of plasma proteins such as fibrin, albumin, and immunoglobulins that have seeped into the vessel wall. In the glomerulus, this process can lead to the development of Kimmel-Steele-Wilson nodules, laminated ball-like deposits of matrix. This nodular form of glomerulosclerosis occurs in about 15 to 30% of patients with long-standing diabetes, and is essentially pathognomonic of the disease. There are 2 more classic histologic changes of the glomeruli in diabetic nephropathy, mesangial expansion and podocyte injury. For that, head over to the renal unit, where we have a more detailed discussion of glomerular pathology, in all its Celtic glory. All right, so we've got leaky capillaries. At the glomerulus, that means extra proteins are leaking into the renal tubule. As a matter of fact, part of routine monitoring for diabetic patients includes periodic urine tests for albumin in the urine, symbolized here by that family album discarded on the floor. Kidney damage can be detected early by the presence of moderate albuminuria, also called microalbuminuria. Without treatment, severe albuminuria is followed by a progressive decrease in GFR and, eventually, end-stage renal disease. Another common target in chronic diabetes mellitus is the retina. As with kidney disease, diabetic retinopathy is caused by injury to the blood vessels and is one of the leading causes of blindness in the United States. Diabetic retinopathy comes in 2 flavors, non-proliferative and proliferative. We'll start with the non-proliferative version of the story. On fundoscopic exam, one of the earliest clinical signs of non-proliferative diabetic retinopathy is the formation of microaneurysms, which look like small red dots of blood vessel outpouchings along the retinal surface. They're represented here by those little cinnamon flecks on the surface of that giant retinal cinnamon candy. As we saw in the kidney, non-enzymatic glycation increases vascular permeability. This leads to leakage of proteins and lipids from retinal capillaries, forming visible exudates. Blood vessel rupture can be seen as characteristic flame hemorrhages, as depicted by the reflection forming those red streaks. Another common finding in diabetic retinopathy is the formation of so-called cotton wool spots. These are pale areas caused by microinfarctions of the retinal nerve fiber layer. Now, how about the proliferative version of diabetic retinopathy? The word proliferative should make you think of neovascularization, or new vessel formation. This occurs when vascular growth factors, especially VEGF, are increased in an attempt to revascularize areas of ischemic or necrotic retina. At Sketchy, VEGF is always represented by a vascular-looking veggie. And as you can imagine, veggies aren't too welcome in Candy Valley.
Don't want to talk, eh? You know what to do, them boys. Come along.
Unfortunately, the neovascularization is disorganized, leading to a number of characteristic findings. First, rupture of the fragile vessels can lead to preretinal hemorrhages, which look like pools of blood throughout the retinal surface. Furthermore, vessels may rupture directly into the vitreous substance, giving it a hazy red appearance, sometimes even with chunks of thrombus floating around. The extensive proliferation of blood vessels can also crowd into the space normally used to help drain the aqueous humor of the eye. Consequently, intraocular pressure increases, as depicted by the rock-hard ocular surface of the Candy King's jawbreaker minions. This ultimately leads to glaucoma. Also, you see how the side of that fruit roll-up rug is, well, rolling up? Proliferative diabetic retinopathy can effectively distort the retina and even lead to retinal detachment. Classically, patients report floaters and flashes, and eventually monocular vision loss. Well, that got violent. You know what? We've been focusing most of our attention on microvascular complications. Time to go big. The macrovascular complications of diabetes mellitus involve large and medium-sized arteries, as well as arterioles. And unfortunately, this story doesn't get much happier from here on out. One of the most characteristic consequences of non-enzymatic glycation is hyaline arteriosclerosis, which involves thickening of arteriolar walls and luminal narrowing due to the deposition of an amorphous hyaline substance. At Sketchy, sclerosis is symbolized by a sclerotic scaly snake. Remember that curly tail? We described this process already, at the glomerulus, where it was called glomerulosclerosis. When it affects the arterioles, naturally, we call it arteriosclerosis. These pathologic changes are not specific to diabetes, and can also be seen in hypertension and old age. The next macrovascular complication to keep in mind is atherosclerosis, represented by this exceedingly large red velvet donut with a gunky athromatous accumulation of cream cheese frosting. The pathogenesis of atherosclerosis in the setting of diabetes is multifactorial, likely driven by chronic inflammation and lipid oxidation. Advanced glycation end products can also disrupt vascular endothelial cell function, which promotes plaque formation. Atherosclerosis is the driving force behind many of the macrovascular complications of diabetes. This includes coronary artery disease, which can lead to myocardial infarction and heart failure. In fact, cardiovascular disease is the most common cause of death in patients with diabetes. Atherosclerosis can also lead to stroke, as represented by that poorly executed stroke of black paint, which will probably be his last. And the final macrovascular complication, peripheral arterial disease, is shown by the evidence of atherosclerosis of the king's upper and lower extremities. Just a sloppy job all around, really. Of course, we have separate videos for coronary artery disease, stroke, and peripheral arterial disease. So, be sure to check those out. I'll be waiting. Don't stand me up this time. All right, that just about covers non-enzymatic glycation and how it affects the body. In summation, bad. All bad. Well, I hate to say it, but things are about to get worse. Because there's another way hyperglycemia wreaks havoc on the body, and that's through osmotic damage. Let's take it down to the molecular level. When glucose enters the cell, it gets modified and is effectively trapped inside. One way this occurs is through an aldose reductase reaction, which converts glucose into sorbitol. Just think of that sorbitol-sweetened cereal filling the bowl as glucose getting trapped in the cell as sorbitol, part of a balanced breakfast. Many tissues then convert sorbitol into usable fructose via sorbitol dehydrogenase. However, some tissues, including the retina, lens, and Schwann cells of the nerves, aren't able to perform that second step, and the sorbitol accumulates. Just cuckoo for sorbitol. This wouldn't be so bad, except that sorbitol is osmotically active, meaning it draws water into the cell, which then causes swelling and tissue damage, snapping,
Maybe.
crackling,
A little
and popping. No. I can't watch. The lens, for instance, lacks sorbitol dehydrogenase, and therefore, in the setting of hyperglycemia, excess sorbitol accumulates. This causes damage to the fibers of the lens, resulting in opacification. That's what we call cataracts. Schwann cells, which normally help form myelin on peripheral nerves, also have a hard time converting sorbitol to fructose. When sorbitol accumulates intracellularly, osmotic damage follows, resulting in demyelination and a peripheral neuropathy. Early on in the disease, patients lose sensation in the bilateral lower extremities, and later on they can lose sensation in the upper extremities. This is described as symmetric neuropathy in a stocking glove distribution, hence the stocking and glove frosting worn by the gingerbread guard. What goes first is usually proprioception and vibratory sensation, which are carried by large fibers. This is in addition to decreased pain, light touch, and temperature sensation, which are carried by small fibers. Additionally, there can be diminished or loss of ankle reflexes. Diabetes is the most common cause of peripheral neuropathy in the US, and peripheral neuropathy is the most common complication of diabetes. Ulcer formation of the lower extremities, especially the foot, is incredibly common in diabetes and is caused by a couple of mechanisms. As we just illustrated, diabetic neuropathy leads to decreased sensation, often in the lower extremities. So if there's some kind of traumatic injury down there, your patient might not even feel it. With ongoing irritation and damage, a minor injury can expand to form a big, nasty ulcer. On top of all of this, peripheral arterial disease is causing poor tissue perfusion, making it harder for the wound to heal. Furthermore, hyperglycemia causes neutrophil dysfunction, further impairing wound healing. Ultimately, this makes the patient vulnerable to secondary infections. In fact, vascular insufficiency can cause areas of ischemia, which are prone to anaerobic infections. In severe cases, gangrene can develop, which may even require amputation. Reenacted here by the daily royal ceremony, which involves removing the Candy King's black gangrenous-looking licorice boots. Gross. Ugh, gross. No, not the gangrene. Black licorice. Ugh, disgusting. Following trauma, diabetes is the second most common reason for amputation of a lower extremity. The loss of proprioception and pain can also make these patients more susceptible to joint damage, especially in their feet and ankles. This pattern of joint damage is so common that injuries of this type are given a special name: Charcot joints. In this scene, however, instead of Charcot joints, think of these chocolate joints decorating the gingerbread man. Additionally, patients can have multiple cranial nerve palsies. The defect often involves the nerves that innervate the extraocular muscles, and by that I mean cranial nerves 3, 4, and 6. Finally, the autonomic nervous system isn't spared either. Damage to the fibers innervating the stomach, many of which are carried by the vagus nerve, can result in gastroparesis. Patients typically present with early satiety, bloating, abdominal pain, nausea, and vomiting. Genitourinary autonomic nerve injury leads to a variety of symptoms, including impotence, as depicted by that floppy lollipop, as well as bladder dysfunction. Diabetic bladder dysfunction involves a diminished ability to sense a full bladder. So patients pee less than they should, and when they do pee, they don't empty their bladder fully. Again, they just can't tell what's going on down there. The bladder then overflows, and urine can trickle out unexpectedly. This is called overflow incontinence. Hence the candies overflowing from that bladder candy dispenser. Autonomic neuropathy involving the cardiovascular system can even lead to orthostatic hypotension and syncope, as well as resting tachycardia. Don't worry about that guy. It happens all the time. Promethean philosophical quandaries aside, just pop a few more out of the oven. Diabetes not only wreaks havoc on the inside, but also causes several characteristic skin changes. Diabetes, especially in combination with obesity, can lead to acanthosis nigricans, a velvety, pigmented plaque that has a predilection for areas such as the back of the neck and axillae, as depicted by the velvety ruffles decorating Queen Candy's dress. A super rare skin condition associated with diabetes is necrobiosis lipoidica. It starts as small yellow to brownish papules and plaques that eventually progress to erosions and ulcerations. I want to wrap up here with infections, so let's bring in those recurring bacterial and fungal lanterns. Patients with diabetes are predisposed to developing infections for a variety of reasons. Recall that sensory neuropathy and vascular insufficiency predispose seemingly minor injuries to recurrence and infection. Also, patients with urinary retention due to autonomic neuropathy are prone to developing UTIs. Additionally, in the setting of hyperglycemia, not only is neutrophil function impaired, but a couple fungi thrive in that sweet, sugary environment, and are therefore more likely to be seen in diabetic patients. This includes Candida albicans, which likes to take over the buccal or vulvovaginal epithelium. And then there's Rhizopus, which goes straight for that sugary blood. The classic manifestation is rhinocerebral mucormycosis, when the mucous membranes and vasculature of the nasal passages and orbit get all necrotic and fungusy. It's pretty much the worst infection ever. Another bug classically associated with the diabetic immunocompromised state is Pseudomonas, a bacteria that can cause malignant external otitis. Check out our sketchy micro videos for more details on Candida, Mucor, Pseudomonas, and more. Just look out for our recurring candy jar symbol, which designates specific bacteria and fungi associated with diabetes. Diabetics are also more likely to develop pyelonephritis, an infection of the kidneys. Ongoing inflammation at the site of recurring infection can eventually lead to scarring of the renal parenchyma, hence our recurring symbol for pyelonephritis, a pylo pineapple. Because the surface of a pineapple is all rough and scarred, you know? Renal infection tends to be more severe in diabetic patients and can even progress to renal papillary necrosis. This typically shows up as apical necrosis of the renal pyramids, resulting in sloughing of the renal papillae and subsequent hematuria and proteinuria. Aside from diabetes, renal papillary necrosis is also associated with urinary tract obstruction, sickle cell anemia, and NSAIDs. Taking a step back now, I think we can all appreciate that diabetes is truly a systemic disease with a number of serious complications. There are microvascular complications, including glomerulopathy and retinopathy. There are macrovascular complications, such as atherosclerosis and arteriosclerosis. And then there's that whole osmotic damage thing, leading to cataracts and nerve damage. Watch out for infections, and really watch out for...
How many likes it takes to get to the center of
gotta
this
go.
conspiracy? Get her!